Hi, uh, is it clear now? Is audio okay? Is audio okay? Is the audio okay? I hope it should be okay now. Okay. So, welcome to Academy, and this is a session for the discussion of the questions which were asked. And please don't blame me for anything which is reported incorrect, because I have just taken it from various resources that are available across the internet. So, Eco, I was saying, God bless you, I'm fine, and I hope all of you are fine. So, those who have given the exam, it's great that you have at least given the exam. Don't worry about the results. Whatever will be the results will be great, and try to just take it as a positive motivation for your NEET PG. So let us just discuss the things. Yeah. Thank you. God bless you. And I was seeing majority of the questions were actually, some of them were direct questions. So there was a question on damage control surgery. So when we talk about damage control surgery, it's a very simple concept, that phase 1 of the damage control surgery is the phase of what? Abbreviated laparotomy. So we have abbreviated laparotomy, and in this abbreviated laparotomy you do only two things. You control the bleeding. So we control the bleeding, and we also control the contamination. So how do you control contamination? By giving thorough lavage and putting in some drains. So try to understand decontamination, yes. Hemorrhage control, yes. And then we take the patient to the phase 2. What is the phase 2, students? That is, the patient goes to ICU, and once the patient is hemodynamically stable, then we take the patient for phase 3. And when you talk about phase 3, what are the important things that we need to understand? That this is a phase where you go for a definite surgery. So remember, vascular anastomosis is not a part of damage control surgery. So I hope most of you, this was a very easy question. Again, we have something on neurogenic shock. So when we talk about neurogenic shock, what is neurogenic shock? This is loss of sympathetic tone. So when there is loss of sympathetic tone, what is the problem that is going to occur in this, students? There will be hypotension. First of all, why? There will be pooling of the blood in the periphery. So hypotension, and along with that, there will be bradycardia. So hypotension and bradycardia is what is the answer for this. Let us try to understand 2-3 more important things. Now, if you see, this is a question of sigmoidvolvulus. I have always been emphasizing on this thing, that just if you see my flashcards, I took this class few days and I've taken this a lot of times. This flashcard series is very famous series of mine, which I've done a lot of discussions, and there is a straightforward question with a similar image. So identify the things, and this was the same image that was expected in the exam and was asked. So very same question was asked, that X-ray of a volvulus. So yes, this is a volvulus. Why? Because the typical shape of volvulus, so you can identify it by seeing the shape of the volvulus. The next thing that you need to understand is, what are the classical signs of a sigmoid volvulus? It's a coffee bean appearance. A typical coffee bean appearance you can have, or you can have the omega sign. But I have a better way of seeing a volvulus, because I always look at the apex. So remember, apex is towards the right upper quadrant. That is seen in case of sigmoid volvulus. However, it is not fixed. As the size of the, you can say, volvulus will increase, do you know, this might go to the left upper quadrant also, but it takes a lot of time. Whereas in case of cecal volvulus, the apex is towards the left upper quadrant. So cecal volvulus, if you talk about, this is how the cecal volvulus is. Okay. So if you see a cecal volvulus, this is like how a cecal volvulus is. The apex is towards the left upper quadrant. So this is what is very important. So this is not a case of cecal volvulus. This is not a case of fecalith. It's a classical sigmoid volvulus. One more sign that you should be knowing, because it's very often asked, that if you take this as a tube, so the inner side of this tube, this is what is a classical bent inner tube sign. So bent inner tube sign, this is where the things are, bent inner tube sign. So this is a classical sigmoid volvulus. Then you had a question on match the following. So whenever you want to make a diagnosis in thyroid, you need to understand that USD Guided FNAC is the gold standard. Why it is USD Guided? I hope you understand that majority of the thyroid nodules are a combination of what? A solid and a cystic area. So if you do a blind FNA, okay, you can localize the nodule, but whether you are aspirating a, you can say necrotic part, colloidal part, or whether you are aspirating the solid part. So by using USD Guided FNA, the chance of reporting a false negative thing is minimized, and this is what is very, 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 very important. So there is a decreased risk of false negative reporting. The second advantage is you can have a simultaneous what? Assessment of the radiological assessment of the or screening of the gland. So this is what is very, 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 very important. Very important. Try to understand 2-3 more things. Breast. When we talk about breast, it is the true cut. The true cut that we have. This is what is very, very, very important. So true cut is what is important here. True cut. Next is when we talk about Marzolin ulcer and lymph node. For lymph node, it is the excision biopsy. So A, we have thyroid as 1, breast we have 2, the D that we have is 3, and C we have as a wedge biopsy. Remember, excision biopsy can be done for even Marzolin ulcer also, but yes, we do a wedge biopsy or a shape biopsy to see whether or no the things are, it's a chronic wound or it has converted into a what? SCC. So we don't know whether it's a Marzolin ulcer, it is a post biopsy that we diagnose. So this is what is the correct order. Now, drug of choice for thyroidectomy to reduce the bleeding. Remember the aim of drugs that we use in thyroidectomy. It is a very simple. So, sorry for the inconvenience. Okay. So when we talk about thyroidectomy, what is the basic concept of thyroidectomy? Answer is we need to have a euthyroid status before every surgery. So propranolol, PTU, they are all helpful in controlling the after effects of, you can say, hyperthyroidism, or you can say the increased cardiac increased incidence of cardiac arrhythmias, etc. But it is the potassium iodide, that is Lugol's iodine, which is having the best thing. So Lugol's iodine is the best thing. Why? Because of the classical Wolff-Chaikoff effect, and this is what is very, very, very important. So you know, both inhibitory and you can say stimulatory effect is seen. So potassium iodide actually will decrease the vascularity of the gland. Otherwise, all these drugs are useful in controlling the euthyroid status. Now, old lady fell down. So the word old, you have a thing that yes, it could be a case of SDH. Then there was an X-ray image given, CT scan image was given. So you can see on the CT that it is classically a what? SDH. And then they have asked that she develops the symptoms of neurological symptoms and headache after a long time. Yeah, that means after few days. What could be the source of bleeding? So if you identify that it is SDH, one thing is very clear, that it is the bridging cortical vessels. So if this is the dura and the skull, and then you have the arachnoid, so between the dura and the arachnoid there are a lot of vessels which are known as bridging cortical vessels, and amongst them, since veins are thinner, it is veins which are prone to get ruptured. So bridging cortical veins, this is what is very, 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 very important. Now then there was a question on RTA. So again, this is a very old question, but you need to understand, whenever we talk about trauma, the resuscitation is taken care by one group, and then primary survey is taken care by another group. And remember, they are all done simultaneously. So practically, if you talk about how we start with the things, in this case, you could have gone for IV cannula. Meanwhile, you started with the assessment, and then you go for cervical spine stabilization and airway. Now, when you talk about securing airway is done first, or stabilization of spine is done first, you need to understand that always, if nothing is given, we give the priority to the patient. If you think it's a case of cervical spine injury, always spine stabilization. But if nothing is given, it is airway, and then so secure airway, and then stabilize what? Cervical spine, stabilize spine. So this is what is very, very, very important. So this is the classical order in this case. Let us move forward. Now, this is a controversial question. Yesterday, I discussed it on my platform also. Now, the lot of things, vitamin B12 deficiency seen after removal of all of the following except. Now, students, if you remove stomach, you know Castle's intrinsic factor is inhibited. Duodenum has some absorption, even jejunum has some absorption, and even ileum has some absorption. So, so this is what is very, 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 very important. So actually, like, I have answered this as ileum, since ileum is very long. Yeah, you cannot. It is not complete ileal resection which I have which we do. All of them. If you resect them, there will be some level of, you can say, malabsorption related to B12. Some of them. Terminal ileum is again a very important site. So yesterday I have given this answer that okay, it's ileal resection, but if you have to see both C and B and D and A, they are all of them are right. All of them are right. But what I feel preferentially now, after going through a lot of resources, that I would mark C better answer as D. So yesterday even I have given an answer D as the right answer, but after going through a lot of things, I would say jejunum would be the safer answer. But actually all four are involved in this. So even duodenum is involved, even jejunum is involved, even ileum is involved, because only terminal part of ileum, so you cannot completely take ileum. So this is a controversial question where after seeing a lot of feedbacks and reviews of the things, I would have gone for jejunum. So in my YouTube channel I have discussed this as D, but now I want to say that okay, jejunum is a better answer than ileum in this case. Now, patient referred from outside hospital with acute necrotizing pancreatitis. So if you are referring a patient, definitely the patient must have been very sick. Yeah. So patient is sick, and this is proven on CT scan where you have a collection also. Can you see? So there is pancreatic ascites along with necrotizing pancreatitis. The patient is not doing well because patient is not maintaining the blood pressure and he is on vasopressor support. So but in these patients you cannot do anything. The only thing now you can plan is reduce some level of pancreatic ascites, and that is why percutaneous aspiration of fluid should be done in this case. Then there was a question on BIRATS. There were features of BIRATS. I hope you know what is BIRATS, breast imaging reporting and data system. I clearly couldn't get the question, so 0 is inconclusive, 1 is negative for any malignancy, and then 2 is benign. So when we talk about 1 and 2, what should be done? These are the patients for annual follow-up. And once we talk about it being inconclusive, you have to repeat scan, or you have to choose an alternate scan for this. So if you have done a mammo, now you can plan a USG also for these patients. 3 is nothing but probably benign. So it's a probably benign, and when we talk about probably benign, then we need to assess what is the probability of it being malignant. So less than 5%, less than 2% risk of being what? There's less than 2% risk of malignancy. However, these are the patients where we go for what? 6 monthly follow-up. Then we have 4, which is nothing but suspicious. And then we have 5, which is suggestive. When we talk about suspicious, what do we mean? More than 5%, or you can say more than 2%, up to 95% risk of what? Malignancy. And you know, we have 4A, that is 2 to 10, 4B more than 10 up to 50, and 4C is more than 50 up to 95%. So these are the patients where core cut biopsy is very, 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 very important strategy. Now when we talk about suggestive, here more than 95% risk is there. Students, there is again a category of patients where you don't know where you already have a diagnosis. Like we have a patient who is diagnosed case of CA breast, and she has been planned for breast conservation therapy. Now before you go for BCS, you should be knowing that, and you should be double assured that there are only 2 or 3 whatever breast lumps you have acknowledged. You should do a scan of the opposite breast also to look for any other tumor. Also, you should be confirming it twice that there are no other tumors other than documented previously. So here you are doing the scan for already diagnosed. So this category is taken as biopsy proven proven, you can say, CA breast, and this is what is very, very, very important. Next is, then there was a question on all except are the contraindications for BCS. History of prior radiation, you know, active SLE, then there is something which is known as active SLE, then there is something which is known as active scleroderma, a family known for P53 mutation, not able to lie supine, so they are all relative contraindication. Even multiple tumors, but tumor less than 4 centimeter is definitely not, and large breast is no more taken. So remember, B is a better answer than D here. So I would have already gone for, even large breast is not a contraindication, but B is an answer of exclusion. B is definitely, so B is far better answer than D in this case. Then there was a question on alcohol-based sanitizer must not be used. Everyone knows that if the hands are soiled, there is no point of using an alcohol-based, so you have to wash them. Doctrine of Monroe Kelly, there was a question on which, MAP was given and CPP was given. So you need to take out what? ICP, intracranial pressure. That was a straightforward question from my notes. And whenever I start with neurosurgery, I actually start with Doctrine of Monroe Kelly. So that's a very important thing. Then a visible mass in the epigastric region with C-KIT mutation. So this is a C-KIT mutation, and remember S100 negative. So that's a mutation that is seen in soft tissue sarcomas, basically soft tissue sarcomas in category of leiomyoma. So it's not a leiomyosarcoma, it's a soft tissue mass with C-KIT mutation, and the answer thus is a GIST. So it's a GIST, which is a very classical answer in this case. Now, not used to diagnose breast cancer, everyone knows that we have a concept of triple assessment. Now, when you talk about triple assessment, what you have to understand, is it low? So triple assessment, when we talk about radiology, yes, it is useful for localization, where is the tumor. Clinical examination is helpful in clinical assessment. So in assessment, whether it's a benign or a malignant looking, and biopsy is actually diagnostic. So these three things are important. When you talk about PET CT, this is a thing that is used for metastatic workup. So it's a tool for metastatic workup, and which is what is very, 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 very important. So this is again a straightforward question from notes. SIRS, what is not? So you need to understand temperature more than 38 degrees Celsius or less than 36 degrees Celsius. Point number one. The second thing that we need to understand is the WBC count. The WBC count more than 12,000 or less than 4,000 per mmQ. And then third is pulse rate more than, or you can say heart rate, whatever you say, pulse rate or heart rate, you say more than 90 per minutes. And then you need to understand one very important thing. The fourth is the respiratory rate. So respiratory rate more than 20 per minutes, or one very important thing that you need to understand is that PaCO2 less than 32 mmHg. So students, here SBP, systolic blood pressure, is not a component. So it's a very easy question. Pulse rate or heart rate, actually they correspond. So that is what is a very simple answer here. Next is, there was a question on stab injury pneumothorax. Remember, what is the treatment of choice? If you talk about the treatment of choice, ultimately it's a tube thoracostomy. So tube thoracostomy, point number one. Remember, if it is unstable patient, you need to understand one very important thing, that the first line shall be a needle thoracostomy. And if it is asked in unstable patient, what is the treatment of choice? Of course, you will have to go for tube thoracostomy. So this is very, very, very simple thing. So gas under a diaphragm, what you will do next? We all know that we will be going for laparotomy. And if you see my most predictable series last year also, this was a question, this year also I've discussed. But try to understand, until and unless a patient is hemodynamically stable, you cannot go forward. So first is always a IV fluids, and then you need to go for exploratory laparotomy. This is what is a benefit of laparoscopy. You are asking me this question, so I will always define a lot of things. Best cost message, lesser pain, early ambulation, and short time, decreased time of discharge. Nowadays even lap chole we are discharging same day. TLS, total laparoscopic hysterectomy, I discharge the patient same day, so no worries. So 19-year-old girl with 6 months swelling moving with deglutition. Always remember, it could be a thyroid swelling versus thyroglossal duct cyst. Remember, when we talk about thyroid versus thyroglossal duct cyst swelling, so movement with deglutition, there are two things that we check. Movement with deglutition, if it moves with deglutition, try to understand this will move and also this will move. Movement with protrusion of tongue, so protrusion of tongue, only a thyroglossal duct cyst will actually move, but thyroid swelling will not move. So first of all, here nothing is given, so you cannot take this as an option. Now with features of muscle invasion, try to understand, when you talk about muscle invasion, this is very simple. Muscle invasion, what is that? This is a feature of malignancy. It's not, invasiveness is not a simple feature, it's a feature of malignancy. So here now you have two options. Now this is also ruled out. So medullary CA versus PTC. Remember, direct invasion is quite less seen in PTC. It is more prominent feature of MTC. So answer here is C. C is the answer. Now correction of order of hypospadiasis, always remember the first thing that you need to do is orthoplasty. So orthoplasty is first thing, and then we actually go for granuloplasty, urethroplasty. And so granuloplasty, you need to go for urethroplasty, and you need to create a meatus simultaneously, so meatoplasty. So actually it is chordy correction is the first thing. Chordy correction is the first thing that you are going to do. So orthoplasty is the first thing that we are planning. Then we go for granulo, urethro and meatoplasty. Number of nodes, if you have to match the following, breast is 10, stomach is 15 lymph nodes, so 16 is acceptable, colon is 12 lymph nodes, and gallbladder anywhere more than 5 is sufficient. So this is what is the order that we have. Again, this is a patient with hematuria. So hematuria with renal mass, and then if you see, this mass is having a distinct orientation on a CT scan. So this is a left sided renal mass with different orientation. And what is the reason? Why? Because it is having negative attenuation with respect to the normal contrast kidney, and minus 20 to minus 30 Hounsfield attenuation, or you can say hypoattenuic things on CT scan belongs to fat. And the only tumor which contains fat is angiomyolipoma. As the name says, if you see angiomyolipoma, tortuous vessel, soft tissues and fat. So the answer here is angiomyolipoma. This is what is very simple. Which of the following should not be given before splenectomy? Remember, when we talk about splenectomy, there is an increased risk of infection, so of encapsulated bacteria. So in case of elective splenectomy, when you are planning an elective, so 2 weeks prior to the surgery, you are going to give H influenzae, pneumococcal, meningococcal, but typhoid vaccine is not given. In case of emergency splenectomy, within 2 days, you need to give Hib. The Hib is the first that is given, Haemophilus influenzae, and then after 2 weeks, you are going to give the pneumococcal and the meningococcal vaccine. So typhoid vaccine is not given. It's a straightforward question. CA gallbladder, what is an early feature? Jaundice is very early feature. Palpable mass, even acute cholecystitis can happen in this case. So among the option that is provided, I would have gone for A as the best answer in this case. Next is for safe resection of the proximal transverse colon. So in this case, you have a proximal transverse colon tumor. Can you see, this is how the colon is? So what are the vascular boundaries that you need to resect off. So this is the you can say superior mesenteric artery, and out of which this is ileocolic, this is right colic, and this is middle colic branch. So middle colic, so this is suppose superior mesenteric. So what are the vessels that you are seeing here? This is the middle colic, this is the left branch of middle colic, this is the right branch of middle colic, this is the right colic, and this is the, you can say, ileocolic. So if you want to do the you can say a tumor for proximal colon, you need to divide it 7 centimeter proximal to IC junction, and then here you need to divide the entire transverse colon distal to the splenic flexure of the colon. So if you want to control the vascular state structures here, so ileocolic is one, you have to ligate, right colic. Remember, complete middle colic trunk. So right branch of middle colic is not ligated, we ligate the direct trunk of the middle colic and we resect it. We go for an extended right hemicolectomy. Most common site for ileocecal TB, it's a very simple question, it's IC junction. Remember, stomach is a rare site for this. Stomach, even liver is also rare site, spleen is also rare site. Then we need to match the following. Rat tail sign is seen in malignancies along the lumens. So eclasia would have been the best answer, but yes, CAGB would have been. CAGB, I'm saying CA esophagus would have been a better answer, but here nothing is given. Yeah, okay. How to crack NEET UG? Tamagno, it's very easy. Don't think about this NEET UG. Don't crack. Life is waste. Just stick to the basics, you will go through. So this is NEET PG discussion going on. So we'll definitely discuss. Definitely discuss. Okay. Next is Nescafe milk is also there. So string sign we seen hypertrophic pyloric stenosis. Why? Because of the prolonged lumen, and when you give a contrast, it goes traversing like a string. So this is what is a hypertrophic pyloric sign. However, this string sign is also seen in ileocecal TB also, but here the inverted umbrella sign is more better option here, and football sign is seen for pneumoperitoneum. This is what. Next is boundaries of triangle of safety. You know triangle of safety, this is pectoralis major, then we have mid axillary line, and then imaginary line going towards the nipple areola complex. This is what is very important, and this is what is a triangle of safety. So at the level of 5th intercostal space, the nipple areola complex corresponds. Yeah, Kellogg's triangle was also asked. No, I don't think. Was it asked? So then we have a case of partial bowel obstruction, weight loss, and a stricture. Partial bowel obstruction, weight loss, stricture is actually seen in inflammatory bowel diseases, and taking the scenario which was mentioned, it would have been the intestinal TB. So this is what is trial of ATT. Okay, Nescafe, if the Kellogg's was also asked, the boundary of Kellogg's are very simple. If that was the question which was asked. So this is the liver, you have the hepatic ducts. So this is the common hepatic duct, this is like this. Then you have the cystic duct, and this is how the gallbladder is. So remember, the first thing that you need to understand, the inferior border of the liver, the common hepatic duct, and the gallbladder. So liver, the common hepatic duct, and the gallbladder plus cystic duct. This is what is cholecystohepatic triangle. This is what is cholecystohepatic triangle. Now try to understand. What you think Kellogg is not a Kellogg, it's a cholecystohepatic triangle. Now this is the cystic artery. So suppose this is the common hepatic and this is the cystic artery coming out. So if you see a small triangle here, that is made up of cystic artery, common hepatic duct, and cystic duct. This is what is a Kellogg's triangle. So Kellogg's is cystic artery, cystic duct. This is what is. बहुत सारे क्वेश्चंस बच्चे सिंपल से थे. या थैंक यू नेस्कैफे, ओके. देन देयर वाज अ क्वेश्चन ऑन सूचर्स. बच्चे, आई हैव बोर्ड यू अ लॉट ऑफ टाइम्स बाय डिस्कसिंग द सूचर्स. ये हमेशा मैं डिस्कस करता था, एंड आई नो दैट दीज अदर थिंग्स विल बी आस्क्ड. प्रोलीन, you know, polypropylene is proline, and this is an ideal suture for hernia repair. Polygalactin is a very good suture for bowel anastomosis. Even polydiaxone. Students, I don't think that this recall is right. It was not a skin closure. It would have been abdominal closure. So abdominal closure, this is what is, if this is given, then polydiaxone is the answer here. And nylon, nothing is given, it is tendon repair. So tendon repair is the suture. Yeah. Thank you. I have taken hit top listed 70 to 80 topics in my flashcard. So I always try to teach the basic topics in that flashcard version. So CA prostate, there was a system EB scan. And why this is known as a super scan? Because you can evaluate the complete body and evaluate the metastatic spread. This was a very simple question. Then post appendicectomy, there was a bleeding. So you need to understand if this is the appendix, and this is the mesoappendix. If you talk about inside this mesoappendix, there is a vessel which is known as appendicular artery. And appendicular artery is a branch of what, students? Yes, ileocolic. So it's a ileocolic basically which needs to be ligated, and here you will see that there is no problem. So if you have a torrential bleeding from the appendicular stump and you don't know, so this is what is very important to go for right ileocolic artery. There is nothing known as left ileocolic artery. आपने ही बनाया था? नहीं, ऐसा नहीं था कि मैंने बनाया था, but try to understand, we just predict the basic topics, and this is the intrinsic nature, that think like a surgeon, and those who are making the question papers, they're all surgeons. So we think that these topics are very easy, these topics are very important, and we concentrate on those topics only. So students, even if you couldn't do well in INI-CET, just concentrate, just don't lose the rhythm, don't lose the momentum. It's the right time, you are on right track. Even if you don't get good marks, just continue to study for your NEET PG. That is a bigger exam and a bigger venue and better chances of getting good, you can say, ranks. So all the best for your NEET PG preparation. Keep on going for the more revision based classes on Unacademy channel also. So till then, bye bye.